introduction about Dr. Nitin Chawla. So he's a pediatrician who is specializing in pediatric emergency critical care and neurology. So he's currently serving as the in charge of pediatrics, pediatric emergency, and PICU. So where he manages state-of-the-art department of pediatrics with level 3 PICU and level 3 nursery, and it is also caters for 12-bedded pediatric emergency unit. So Dr. Nitin has 15 years of pediatric experience and more than a decade of focus expert neonatal and pediatric emergencies. So Sir is also currently serving as a core national faculty for IAP guidelines on pediatric emergency. He has also contributed as a chief academic editor for IAP textbook of pediatric and neonatal emergency. So, to his name, he has multiple awards such as Doctor Excellence Award 2025, Guardian of Pediatric Health 2024, and Best Doctor Award awarded by Red Cross Society, and Dr. APJ Abdul Kalam Young Innovator Award in 2023. So, we hope this will be an interesting lecture. So, over to you, sir.
Thank you, Sundar. Small correction, I'm not in charge of pediatric intensive care at my unit. I am focused on pediatric emergency and trauma, and I believe well managed emergency will make life easier of intensivist at all the
Yeah,
levels.
definitely. So, management starts from time zero, which is at the emergency room.
Yes. So, is my slide visible?
Ah, yes.
Okay, great. So, hi everyone, we will be going ahead with our talk on pediatric emergency. We will be saving the future by acting smartly. We will go by first case, which is a 5-year-old female who presented with chief complaints of seizure for 10 minutes, loss of consciousness for 20 minutes. There is no history of hospitalization in past, no family history of seizures, and there is history of excessive crying with maybe a bite 2 hours back as per the family. When this On examination, the heart rate was 140, BP was 78 by 32, which was pretty low for the child. Peripheries were cool, pulsations were poor, CRT is prolonged, GCS is even V1, M1, sorry for the mistype. There was no local sinosting although. Airway was secured in emergency. Child was ventilated in view of poor sensorium. The bolus was given. MBG revealed 7.39 pH of bicarb of 25 and lactate elevated. So, considering our resources at that time, we started on dobutamine and 10 mics per kg per minute was the start. Although there are various other drugs, but we chose to start with dobutamine, considering confidence of the clinician at that time on spot. Hemoglobin of this child was 13. Urine for hemoglobin was positive. Differential count was acceptable. APTT and PT were normal. Sugars were normal. TLC was 15,600. Because of one query history of sting and known area for typical offender, we were thinking on it as a scorpion bite. We took the child in PICU. CRT was 3 seconds after bolus. BP improved, heart rate decreased. Echo done revealed that LVF is 55% on inotropic support. Renal function, liver function, all were normal. And considering scorpion sting, we gave first dose of 30 mics per kg of prazosin. Within 24 hours, sensorium improved. Extubation happened at 30 hours. 4 doses prazosin were given. Inotropic support were weaned and stopped by 48 hours. Child was shifted by 60th, discharged by 96th hour. We'll go to case 2 now, and then we will go with detailed management discussion and other aspects. This 10-year-old child who presented with chief complaint of pain in right dorsum of sole and breathing difficulty. He was returning from home in an under construction site and felt intense pain in right lower limb. While he examined his lower limb, he noticed that these are the two bite marks present. And then, after searching nearby, a snake was found. It was killed and was brought in the cardboard box by the family, which I believe many of you have seen when you practice in rural suburban setups when there is associated snake bites in and around. Post bite, child had complained of slight pain in lower limb, increased sweating. On examination, there was technically no abnormality, but considering anxiety, history of snake bite with local examination of bite mark with no erythema, we still took the child in PICU. With BP, with the saturation low, 1 liter oxygen was started, and ultimate was decreased and stopped. Anti-snake venom was arranged, not given. ECG was done, documented, and all the vitals, all the lab reports were done, suggestive of everything being normal. Within 24 hours after observation, there was no evidence of envenomation. Child's anxiety decreased over 12 hours, orally allowed after 12 hours, shifted out and discharged after 30 hours. Another case, another way how snake has presented to us. So 7-year-old male referred by nearby hospital as declared dead. Status post CPR intubated with dilated pupil. History reveals sudden collapse noticed by mother who is a daily wage worker in a building, and they have heard about snake bites nearby in nearby places. When we received the kid, child was on ventilator, rate of 24, BP was 82 by 42, CRT 3 second, GCS E1, VT and M1. Local examination was not significant, peripheries were warm. When we received the child in view of poor cardiovascular status, we put one EJV, bolus, inotropy support, and we started the child on ASV and also on neostigmine, considering rapid deterioration. And mainly, we were able to understand that there is neurological weakness mostly rather than hematological presentation. And we also continued this neostigmine every half an hour. So in PICU, the pupillary reflexes came back after 4 hours. Ventilatory requirement decreased at 6 hours. Child self-extubated at 8 hours. Continuous monitoring happened till 16. Shifted to ward next night. Discharged next morning because of financial and also because of parent anxiety. They were from a specific tribe where stay in hospital is considered as a taboo. So these were the two life threatening presentation and one non threatening presentation of scorpion and snake. Now we go ahead to understand what actually is all science behind and how epidemiology of spread of this virus, this snake bite and scorpion stings happen. So technically in India there are 86 species of scorpion. Two are of very much importance to all medical professionals. Indian red scorpion, that is Mesopithecus tamulus, and black scorpion, that is Palaminus vermidarum. Endemic regions are known. Where we are managing, we will know. We should also remember that scorpions are not aggressive creatures. They don't hunt for prey, they wait. They hunt specifically during night. They hide in crevices and burrows during day to avoid the light. Accidental human stinging is most common reason because these scorpions, when touched while in hiding, they sting, and the sting occurs in hands and feet. Why this history is important? Because nowadays most of the adolescent and some of the families, when they go out for 2 to 3 short weekend, they go to places where there is possibility of these creatures hiding, and caves and associated trek may be the site where scorpion bite and associated complication by these stings will be seen. So specifically, the scorpion venom, it has a very short half-life of 5 to 6 minutes and peak tissue concentration of 37 minutes. Within this time, as it enters circulation rapidly, it induces complication in all the organs. Pathophysiologically, it opens up sodium channels and inhibits calcium-dependent potassium channels and thus initiate a autonomic storm. So initially there will be transient parasympathetic symptoms such as vomiting, profuse sweating, salivation, bradycardia, VPCs, even priapism in male and hypotension, and prolonged sympathetic symptoms such as cold peripheries, hypertension, tachycardia, pulmonary edema, shock. And when we see pathophysiologically, there are nearly all the vital systems which we learn in pathophysiology get activated. So there is autonomic storm, catecholamine release, increases extracellular fluid volume, stimulation of RAS, angiotensin level increases, peripheral vasoconstriction increases, hypertension increases, coronary vasoconstriction happens, pulmonary edema happens, myocardial oxygen consumption increases. This increased oxygen consumption can lead to arrhythmia and even lead to heart failure if not managed well with the right drug. So, when we talk about neurotoxics, local effects, they might be minimal or most of the time in 50% cases they are even absent. There will be a very sharp burning sensation of pain with some pruritus, erythema, local tissue swelling, ascending hyperesthesia has also been reported. This paresthesia is the last symptom to resolve before the victim recovers. So, in a nutshell, autonomic effects comprises of hyperthermia and sympathetic hypertension, mainly arrhythmia, pulmonary edema, hyperglycemia, diaphoresis, piloerection, hyperexcitability, and convulsions. And because of parasympathetic system activation, sludge, that is salivation, lacrimation, urination, diarrhea, gastric emesis, rhinorrhea, bronchorrhea, fluid from everywhere will be increasing, priapism, generalized weakness, meiosis, dysphagia. So in three, sorry for the quality of image. In three headings, if we divide scorpion sting, benign means only local pain and no other symptom. Potentially dangerous from 0 to 48 hours, there will be movement from autonomic storm leading from parasympathetic to sympathetic, and prazosin here will prevent the death. And invariably fatal in encephalopathy, convulsions, aphasia, hemiplegia, um, respiratory failure. In our case, it was encephalopathy and convulsions. There will be dilated peripheral veins in potentially dangerous warm extremities. Reappearance of pain will happen and no paresthesias. And at this time, if we keep a close differential of local area related sudden deterioration unexplained, keeping scorpion sting as one of the differential and initiating prazosin, then it will save life for sure in those who need some help. In central nervous system, infrequently encountered but fatal presentations are encephalopathy, stroke, both cerebral hemorrhage and thrombosis has been seen, and central respiratory failure, and also conversion within 1 to 2 hours of sting. These signs occur within few minutes and also last for 24 to 72 hours, and there is no specific sequence in which they happen. And sometimes a false recovery can also have a complete relapse if we have not managed the toxin properly. In cardiovascular, pulmonary edema, congestive heart failure, myocardial infarction, arrhythmias, hypertension or hypotension as per the stage of autonomic storm, presence of gallop rhythm, and myocarditis. These all will be present at some point of time in dangerous phase, and this will develop between 30 minutes to 3 hours after the absorption of the poison has happened. Respiratory depression will present as dyspnea, cyanosis, hemoptysis, or ARDS, and in GI there will be associated pancreatic and liver dysfunction. Even necrosis of liver is seen. Renal failure, oliguria, hematuria, acidosis, metabolic disorders, raised triglyceridemia because of poor insulin secretion has been reported. And it has been graded by Sanatan Krishnan grading in grade 1 peripheral circulatory failure with good prognosis. Grade 2 is above, that is peripheral circulatory failure with hypotension, with cold peripheries, with myocarditis. And if there is myocarditis and associated CNS failure, it is grade 3. In our case, it was grade 3. And with supportive treatment with prazosin, which is a complete post-synaptic alpha-1 adrenoreceptor antagonist, which is the line of treatment of management of scorpion sting. This suppresses sympathetic outflow, activates venom-inhibited potassium channels, it decreases the preload, afterload, and blood pressure without increasing the heart rate and without increasing the oxygen consumption by the heart, and it reverses the metabolic and hormonal effect of alpha receptor stimulation. Peak concentration of prazosin happens in 1 to 3 hours and its half-life is 2 to 3 hours. Prazosin is a cellular and pharmacological antidote to action of scorpion venom, and it is also cardioprotective. Dosage is available is one tablet of 1 milligram, 2.5 milligram, 5 milligram, and dose recommended is 30 mics per kg per dose. And sustained release tablets are not recommended in this situation. Prazosin should be repeated in the same dose at the end of 3 hours according to the clinical response, and later every 6 hours till extremities are warm, dry, and peripheral veins are easily visible. So this clinical guide helps you to define how much toxin you need to the symptoms need to be averted by usage of blockade with the toxin already in play. Why are we not putting anti-scorpion venom? Because half-life is 30-minute, distribution is rapid. If within 30 minutes, if we have given up to 4 hours also, it has been shown. But we will go in next slides when we see that usage of anti-snake, anti-scorpion venom has not been, first it is not available in India, and second it has not shown very promising as care pattern in India per se, because of non-availability also, and because of poor referral and delayed referral to equipped ERs. We should always remember that when scorpion sting history is there but symptoms are not suggestive of autonomic storm and there is only benign presentation of pain, then prazosin is not indicated. It can be given irrespective of the blood pressure, and there is no hypovolemia associated in such cases. Time lapse between sting and administration of prazosin for symptoms of autonomic storm determines the outcome. And if you identify by putting a right differential, you will be able to give the right drug and help the child efficiently. Like I said, anti-scorpion venom, it reaches its target too rapidly, and within 30 minutes it can reverse the effect. But for clinical usage, anti-venom against the toxin of Indian scorpion is not available. Other unhelpful treatment which are regularly being given without knowing are lytic cocktail of pethidine, promethazine, chlorpromazine, morphine for pain, steroid for considering it as shock, atropine for parasympathetic symptoms as as poisoning, and nifedipine, ACE inhibitors. So keeping differential will help you to decide one drug which is which should be available in your emergency department if you are into suburban or rural India, or you are a referral center for such problems. What are known complications? Dilated cardiomyopathy, ankylosis of small joint if sting has happened at the joint, rhabdomyolysis, persistent paresthesia, seizures, death, shock, cardiac arrest, respiratory arrest, antivenom anaphylaxis, and serum sickness. So if we divide scorpion sting in 5 stages, 0 to 4, 4 to 6, 6 to 10, 0 to 6 is fourth stage with massive pulmonary edema or more than 12 hours with warm extremities tachycardia. Then symptom wise also we have in stage 1 from 0 to 4 either benign symptom which doesn't need prazosin or anything, but if symptoms are suggestive of bridge between parasympathetic and sympathetic function, hyperactivity, sweating, salivation, hypertension, cold extremities, priapism, then if we have ASV in the equipped settings, we will start with ASV and prazosin. If hypertension, tachycardia, cold extremity, stage 2, prazosin. If tachycardia, hypertension, pulmonary edema, cold extremities, that means cardiac dysfunction is setting in, then start with inotropic support, start with NIV. If sensorium is bad, then go with MV, mechanical ventilation, anti-scorpion venom plus prazosin. In India, as anti-snake venom is not available, and few participants from other nations also will be viewing this. So if you have it, then anti-scorpion venom should be considered. Massive pulmonary edema. If there is massive pulmonary edema, then managing pulmonary edema as per your ICU protocol should be there. Maintaining BP should be there. Affecting all the beneficial steps without increasing myocardial oxygen demand will be of great help. If BP is low and inotropic support with dobutamine in your resource setting is available, then start with cardiac dysfunction, dobutamine at 10 mics per kg and titrate accordingly. Important aspect which I generally ensure that should be known to everyone is the prevention. So we have false ceilings at most of the places nowadays. False ceiling with under loose tiles of the roof and bamboo cot, where many mosquito nets are used to protect from scorpion sting, should be utilized. In endemic areas where venom can sting on the clothing, or so shoes should be those shoes which are high ankle, and if packages are received, then they should be vigorously shaken before we check them out. We should not uh, put hands in any of the vacant bags which are usually being hanged outside in suburban settings, or in one day outing and outskirts resort and things like that. Pesticide like organophosphorus, pyrethrins, and chlorinated hydrocarbons are known to kill scorpions, so can be considered in and around the areas. And before school opens in month of June, or if rain is causing some type of blockage in school opening, then ensure that all the tables and rooms such as roof, wall, floors should be thoroughly cleaned and washed. And table desk in schools also have that flap, so they should be checked. So scorpion venom is a potent sympathetic stimulator. Cardiac manifestations are very common in Indian red scorpion. Hemorrhagic and ischemic strokes are known to occur. CNS involvement indicates poor prognosis. Prazosin alpha adrenoreceptor antagonist is antidote to venom action, and time lapse between sting and prazosin administration determines the outcome. So now we go to the second part of our presentation, that is snake. So we have four variety of snakes which are poisonous. First is cobra, then is krait, then is Russell viper, then is saw-scaled viper. The venom in all these snakes is synthesized by modified salivary gland and is injected to special channeled or grooved teeth called fangs. In India, as per WHO, 11,000 deaths happen per annum and 83,000 bite happen. It is the capital of snake bite in world. Male to female ratio is 2 is to 1, where majority of bites have been noticed in the lower extremities. First aid for snake bite is do it right. It consists of reassure the patient, immobilize in the same way as a fractured limb, and go to hospital immediately. Tell your doctors about any systemic symptoms. If you go to school health programs, ensure you tell that do it right is the right way of managing a snake bite. What you should not do. So, when you have snake bite, you should not apply a tourniquet. When you have snake bite, you do not wash the bite site with soap or any other solution to remove the venom. You do not put incisions or cuts in or near the bitten area. You do not freeze or apply extreme cold. You do not apply any kind of herbal or folk remedy. You do not attempt to suck out venom. So, over and above, this help in managing the children, and also this helps in avoiding further complication. When venom has not been injected, like in our case, this is the time when we have to understand that every snake bite is not poisonous. But after every bite, to have anxiety is very much common. So do not push anti snake venom if you do not have symptoms of envenomation. But at the same time, don't forget to arrange anti snake venom like we anticipated and arranged in case number one. Vasovagal attack is a known complication in any stressful situation, specifically in adolescent. They present with slowing of heart rate, further collapse to get their rates back, and first aid and traditional treatment usually help them. Local symptoms and signs in the bitten part comprises of fang pain. There can be local pain, there can be local bleeding, there can be bruising, there can be lymphangitis, inflammation, blistering, necrosis, abscess. All kind of inflammation will be seen. Systemic symptoms of envenomation comprises of generalized symptoms such as nausea, vomiting, weakness, drowsiness, dizziness, faintness. On evaluation, even arrhythmias, edema, cardiac arrest, hypotension, bleeding from recent wounds if it is a hematological abnormality after snake bite, such as Viperidae family, and spontaneous systemic bleeding from gums, epistaxis, bleeding from into tears, hemoptysis. So bleeding from all the sides, all the cavities, all the holes of the body starts happening. If it is a neurological bite, which happened after Russell Viper, there are drowsiness, paresthesia, abnormality of taste and smell, heavy eyelid, ptosis, paralysis of facial muscles, difficulty in opening mouth and showing tongue, weakness of other muscles innervated by cranial nerves, aphonia, respiratory and generalized flaccid paralysis, generalized pain, trismus, myoglobinuria, hyperkalemia, cardiac arrest, loin pain, hematuria, hiccup, nausea, pleuritic chest pain, all in variety of symptoms of various organs can be seen. To have a ready reckoner as a picture, in Oskis also. If you see this picture of bleeding spontaneously from sulci in the mouth in a child who is obtunded, then always consider snake bite. If the posture of the paralysis is such that it looks like a broken neck, then it is most likely envenomation. 20 WBCT is 20-minute whole blood clotting test, which is considered as a reliable test of coagulation to be carried on the bedside in the glass tube. So, another good thing which you should always ask your pathology department is to keep glass tubes and try to keep at least 4 glass tubes in your emergency department. Test of the 20-minute whole blood clotting test should be carried after every 30 minutes from admission for 3 hours and then hourly after that. Why? We will talk about it in upcoming slides. When you're dealing with a snake bite and there is hematological abnormalities, bleeding happening, then evaluate as any other case of bleeding disorder. Go with CBP check for hemoglobin, platelet count, peripheral smear for PT, APTT, DIC by D dimer, FDP, urine for myoglobinuria, hemoglobin protein urea, RBC, serum creatinine, potassium, oxygen saturation, and ABG to look for lactates. How are you going to manage this child? You manage by managing pain. Most of the time, because of effect of Bollywood, we uh, have toniquets which are already in place. then then comes the role of ASV, anti-snake venom, where anti-snake venom will show that how to administer anti-snake venom is an important aspect. Dosage and pre-meds, adverse reaction, repeat dosage of ASV, and late dosage, everything need to be taken into consideration. Treatment phase starts by managing the pain, and NSAID should be avoided because they increases technically the bleeding part in any circumstance. Handling toniquets also need very important consideration. First, it is not recommended to remove toniquet immediately as soon as the child has been received in your emergency, and sudden removal can actually lead to massive surge of venom, so which will lead to further deterioration of hypotension and paralysis. Always remember that before removal of toniquet, check for the presence of distal pulses. If they are absent or occluded, that means the arterial pressure artery is occluded, then inform, note in your ER notes, and put a blood pressure cuff above the toniquet, inflate it, and then slowly uh, remove the toniquet and keep the pressure decreasing gradually. Only once you have safeguard that toniquet is removed and now the blood pressure cuff is technically working as a toniquet so that it can be reduced in a guarded format. Why it is important? Like I said, if you put a surge and a lot of toxin is released into circulation, further deterioration will come. Mainstay of snake bite is anti-snake venom. Polyvalent anti-snake venom against all the 4 common species is available. There is no monovalent anti-snake venom present. That is the reason we should also tell the general public to not chase the snake and rather bring the patient immediately to the nearby ER, because we have anti-snake venom which will apply to all nearly all known poisonous snakes. For ASV, we should know that it is available in 2 forms, lyophilized and liquid form. 2 years shelf life of liquid form and reliable cold chain is mandatory. Lyophilized has 5 year shelf life and can be reconstituted into 10 ml vial. So anti-snake venom should be considered only if there is definite sign of envenomation like coagulopathy or neurotoxicity, or even if severe local symptom where the swelling has rapidly crossed the joint and involved the half of the bite limb in absence of toniquet. Also, if the toniquet has been removed for more than 1 hour and swelling is rapidly increasing, then this should also be considered as venom generated rather than toniquet induced. When you're giving any biological product, always ensure that anaphylaxis should be also on your um cards. So you ensure that If you see any kind of reactions, minor can be managed with hydrocot 10 mg per kg with antihistaminic 0.2 mg per kg IV, and there is no need for test dose of ASV. If it is mild envenomation, that is systemic symptoms manifest for more than 3 hours after bite, you give 8 to 10 vials. And if it is severe envenomation that within 3 hours after bite you have seen the patient and systemic symptoms are in there, neurotoxic or hemotoxic, you will go with 8 vials. Each vial is 10 ml of reconstituted ASV. Children or adult both should receive same amount of ASV because bite of snake will not differentiate between gender, age, race, creed, weight, size. ASV should be administered over 1 hour, and there is no benefit of administering each dose over a longer period or lengthening the period of administration of ASV. Actually, it is counterproductive. If any of the reaction are seen after starting ASV, which includes itching, fever, shaking chills, nausea, vomiting, diarrhea, hypotension, tachycardia, bronchospasm, angioedema, you should be ready with zero point 0.01 mg per kg of 1 is to 1000 dilution or 1 is to 1000 adrenaline, which is available readily. So zero point 0.5 mg maximum you can give. So pediatric dose of 0.01 mg per kg body weight of adrenaline IM is one another thing which you should take home from this class. Always remember that if you are a general pediatrician, you have a OP where you give vaccination. Even vaccination can cause anaphylaxis. Adrenaline and 1 ml 1 cc syringe will cost you 7 to 8 rupees. Keeping one adrenaline loaded and maximum of 0.5 mg, considering 60 kg as the size of adult. So by that, if zero point 0.1 for 10 kg, zero point 0.2 for 20, zero point 0.3 for 30, zero point 0.4 for 40, zero point 0.5 for 50 and above. This is the dosage of adrenaline which you should remember IM to be given in which you are pro. If after giving and still the condition is worsening, you can repeat. And if still condition is deteriorating, you can give third, but usually in two doses adrenaline works and anaphylactic shock can be reversed and anaphylaxis can be sorted. But treatment of snake venom is anti-snake venom, so we retry after managing the anaphylaxis after 10 to 15 minutes because otherwise snake venom is going to kill. And we should remember that IM adrenaline has 8 minutes before it reaches the plasma levels, and if we by chance have given through subcutaneous, it takes 34 minutes. So choose IM. In anti-hemostatic bites, once the initial dose of anti-snake venom has been given over 1 hour, there is no need of further ASV for 6 hours. And like I said, 30 minute each, 20-minute whole blood clotting test should be done. So, and after that, every hourly, and after that, every 6 hourly, it should be done if additional ASV is required. This usual timeline is the usual timeline of liver to regenerate its clotting factors. If whole blood clotting test is more than 20 minutes, then you have to repeat 5 to 10 while that is either half or full dose as per your unit protocols. And 6 hourly is the time window after envenomation and ASV given. It is expected that now liver will kick in and clotting factors will be replenished. If it is still not getting better, then you have to identify which type of snake is this, which is toxin, I mean, which has toxicity, but our polyvalent ASV is not working. So that means you have to notify to the authorities. What worked in our patient who was declared dead in nearby hospital was neostigmine because we identified it as a neurological manifestation of snake bite. We started neostigmine in our ER at dose of zero point zero 0.02 mg per kg, and in children we go with zero point zero 0.04 mg per kg IM or zero point zero 0.02 mg per kg IV. We pre-treat with atropine at zero point zero 0.02 mg per kg. There is no minimum dose now, and if patient here was showing clear signs of neurotoxicity with mydriasis, uh, upward there we were not having a trophonium at our place, and we started the neostigmine, and we were able to check every hour, and we saw improvement. We initiated neostigmine for first 2 hours. We actually give it at 30 to 45 minutes, and then we shifted to hourly. And then once we saw that all the symptoms and envenomation and muscle weaknesses were getting reversed. We were able to see that self extubation at 4 o'clock in the morning has happened. So to revisit, neostigmine should be continued at a dose of zero point zero 0.01 mg per kg every hourly for next 6 to 8 hours if you are dealing with neurological symptoms of snake venom envenomation. And atropine should be given at zero point zero 0.02 mg, dilute it in 8 ml, and give 1 ml per hour for next 8 hours. This is a crowded slide, but an important one. Neostigmine works by inhibiting acetylcholine esterase, and which is an enzyme to break down acetylcholine, which is a neurotransmitter for muscle contraction. Because of its inavailability and consumption by acetylcholine esterase, the acetylcholine is lost. So, by increasing its availability, neostigmine help to overcome venom-induced blockade and improve muscle function. At the same time, neostigmine will also cause muscarinic side effect, and atropine is going to work on these muscarinic side effect, and it will thus decrease the potential complication associated with neostigmine administration. In neurotoxic envenomation, the ASV regime is not clear. Like in hematological manifestation, we check WBCT and we assess if it is still positive that no clotting is happening, we repeat. But in neurotoxic envenomation, after 1 to 2 hours of initial dose in neostigmine, patient is reassessed and symptoms if are worsening or are not improving, then we plan to give second dose. And again the second dose is full envenomation anti snake venom 10 vials, and then after second ASV we discontinue. We don't give 3 4, we go with 2 doses of ASV. Once the patient has developed respiratory failure, like in our case, and has also received 20 vial, in our case we have given only 10, ASV therapy should be discontinued, assuming that this much amount of venom was infused and this much amount of anti-snake venom will technically neutralize it. Now, the respiratory paralysis which has happened will ultimately be better after our respiratory support and patient general condition improves. So, ventilation is needed as a support to maintain the physiological changes. If the victim has arrived late and you performed a 20-minute whole blood clotting test and coagulopathy is still present, then you have to administer ASV, otherwise, child will develop renal failure. In case, like I said, neurotoxic envenomation, 1 dose has been given of ASV and there is no unbound venom present, you document improvement, no need to repeat. And respiratory support is primarily a support, cardiac support is primarily a support to maintain the physiological challenges. What we have to see after we have started ASV, so generally child will feel better. There will be some pain which may disappear quickly, spontaneous bleeding which will stop within 15 to 30 minutes, blood coagulability will start happening, and within 3 to 9 hours of giving ASV 1 dose you will see improvement. That is, after 4 time WBCT check you will see betterment. Blood pressure will start increasing after 30 to 60 minutes. Arrhythmia will start getting resolving. Neurotoxic envenomation will start showing improvement after 30 minutes, but it may take several hours also. And always remember, victims should be followed after discharge from the hospital, and they also should be given adequate knowledge to avoid such bites again. And if patient has been discharged within 24 hours, then they should be told that possibility of altered sensorium, pain, swelling, bite of site infection, all will be there, because hypoxic injury can lead to deterioration of cerebral status. Snake venom led to fall. Snake venom led to hypoxia because of respiratory compromise, related neurological insults. Everything should be documented and should be told. Patient should also be explained about serum sickness, which may manifest after 5 to 10 days of ASV. And serum sickness is a type 3 type of hypersensitivity where body reacts to protein in certain medications such as vaccines or antisera, which are non-human from animal sources. And they are characterized by formation of immune complexes that can deposit in various tissue, leading to inflammation and range of symptoms. If at all there are symptoms associated with that, we treat them with asymptomatic treatment, NSAID for pain, and in severe cases of renal dysfunction, we hospitalize them. So, with this, I conclude my talk, and uh, it was great to talk with all of you and share my views and my opinions on snakebite. Here to you,
Uh,
Sundar.
yeah. So thank you, Dr. Nitin sir, about this wonderful class about regarding scorpion and snake bite management. So you're given a wonderful lecture. So you covered almost everything. So what is the pathogenesis? How you treat? What are the emergency signs? So I would also like to share a few experience which I have seen over the last six years in my career. So like we had one patient, so who was referred from outside. So was
Mhm.
he was exactly as you mentioned, unresponsive, was intubated. So we initially didn't think of as a snake bite, but actually when we changed the cannula, they
Bleeding didn't
incidentally
stop.
applied, yeah, they have applied the dressing on the cannula or the snake bite. So when we changed the cannula or when we put the inside the central line and took out the peripheral line, we found that the patient had a fang mark over there.
Okay.
So from them we learned that if you are having any suspicion of any animal bites or any scorpion, expose the patient fully,
Yes.
examine the parts thoroughly. So that's one thing I have learned. And the second thing is regarding the public knowledge about snakebite management because they have seen all from movies and television. So their first instinct is to tie the limb, suck out the venom. But we should give a good knowledge, disseminate this knowledge upon the public, what to do, what not to do in a snake bite. Thankfully, government has a free availability of anti-snake venom in almost everywhere in the public hospital. And regarding on some places, the incidence of snake environment is such high that it is far surpasses the GBS. So, especially in rural areas, the first diagnosis when a patient comes with the acute flaccid paralysis. So, first diagnosis should be snake envenomation, especially when you have a very large incidence of snake. And this trait are especially notorious as far as I've seen, because the typical histories because these usually happen in the rural areas. So family usually says we slept as a family in the night, but when we woke up in the morning, the
Not
kid has
waking up.
not woken up. Yeah. So because this is usually painless, so this should be a very high index of suspicion, what I have felt. And
Yes.
also we have seen one more case regarding a hemotoxic snake bite. So in fact,
Mm.
the child presented with refractory shock. Hello.
Yeah. Hello. Sundar, am I audible?
Yes, Dr. Nitin, you are audible.
Hello.
Yeah.
Is
Yeah.
it
Sundar.
audible?
Yes. Yes.
Yeah. So actually, we lost this child when we were doing in MD because I was from Chennai. So it was actually a pituitary apoplexy. So this was hemotoxic snake bite, which caused a fatal pituitary hemorrhage. So one of the diagnosis for a shock in a hemotoxic snake bite, we usually think it is DIC, sepsis, and a hemorrhagic shock. But even a bleeding into pituitary that can cause a fulminant endocrine crisis. So you beautifully mentioned about all the envenomation, the management. So we have a few questions here. So would you like to answer, sir?
Yes, I'm looking at them. I'll go with the last question: maintenance dose and duration of atropine. So we'll go with 0.02 mg per kg. We dilute it in 8 ml normal saline and we run it over 8 hours, and 1 ml per hour to be given as a medication to cover up the muscarinic side effects of neostigmine, where neostigmine is given at 0.01 mg per kg. And always remember that in our case also the work of neostigmine helped us. Although 30 to 45 minutes we repeated, you have a good window of 1 hour to go ahead. And we are in urban settings, and snake was not on our mind. But when family told us that there has been history of snake bite in and around. Then we thought that probably we because what we were of an opinion that small hospital doesn't want to declare dead, so they are referring the child, so we should be ready with BD and all other MLCs. But when we received the child was dilated pupil, heart was there, and pulses were felt. But we thought it was amazing CPR done outside, but ultimately picture changed completely. So neostigmine really work,
What?
but what really works is to think that you have to use neostigmine and this is a scorpion and this is a
Yeah.
snake bite.
So basically, we need to have a very high index of suspicion,
Yes.
especially when you're working in a urban area where we don't see these kind of cases. So that is where the diagnosis comes in. The index of suspicion, that is, I feel, is most important.
Yes. Another
Yeah.
question is, shall we give atropine, neostigmine in every snake bite? No, you have to first see whether there are any symptoms associated. That's the reason I kept two cases. One case was only pain and vasovagal syncope. So always react on the vitals in emergency, not on the diagnosis which you have been told. So the reason of sharing this background history of dead boy coming from nearby, as a human we have a tendency to start making our own thought processes for the situation, and sometimes situation is entirely different. So no is the answer, that every snake bite doesn't need atropine neostigmine. Neurotoxic symptoms of snake bite with cobra bites or Elapidae family bites, viper bites, will need neostigmine and also will need atropine to manage the muscarinic side effect. But most importantly, every snake bite will need anti-snake venom. And having 4 to 5 glass test tubes in your ER will be a very good way of looking. Sudeep is asking about difference in bite marks of venom and non-venomous snake bite. Technically, don't search for them. Jaw mark of a human bite and two fang bite. In first case, when we saw two fang bite, it was a non-poison, and in other case, who was nearly considered as dead, was not having any bite mark. Why should we not give prophylactic ASV when it's confirmed snake bite? So when it is confirmed snake bite and snake, I'll put it in a form of discussion. If snake is full, they don't want to kill the prey. They just want to bite and tell ki please don't disturb me, and they walk away. Every snake will not push their venom. If you recount my slide, I mentioned there's a specialized teeth which are called fangs, which will be activated only if they want. Not every time they push in the venom, and they are always not full with venom. It need to be prepared in their own body. So if they have recently killed a prey and eaten it and are satisfied, they will not probably push in their venom. So bite will happen, poison will not come. So keep watching for vitals, and it rapidly deteriorates. If you see bleeding happening in the gum spontaneously, epistaxis, tears, vagina, perurethra, perrectal, vomit, and sensorium is bad. Child is bleeding from everywhere. Probably you are dealing with hematological manifestation of snake. So yes. Secondly, snake venom is a very notorious product to cause anaphylaxis and serum sickness as well. So if you are not sure, you keep it ready. And if your team has decided to go ahead with anti-snake venom, considering the history, considering the presentation, then also be ready to manage anaphylaxis and also be ready to counsel for serum sickness and be ready to manage that as well. Sudeep, I've answered. So Raj says okay, so ASV can be repeated or not if reaction to first dose appear. If you have seen that child is improving after first dose of anti-snake venom, you need not to repeat the dosage. If the deterioration is continuous or the response is not progressively happening, then you consider giving. After second dose of ASV of 10 vials, so total 20 vials, there is no role of giving third dose because venom glands will push in that much amount of venom only, and giving 10 vials, 8 to 10 vials in first go and 8 to 10 vials in second go is more than enough. After scorpion bite, cardiac arrhythmia response to prazosin is remarkable but comes back as soon the drug level facts. So prolonged prazosin therapy to continue. Yeah, absolutely, sir. Absolutely. Valid point taken. And the comment is from Dr. Debasis. So prazosin is a drug which is going to alpha block the alpha receptors. And in scorpion sting. This autonomic storm is going to take time to get recovered, and we are not technically removing the offending agent. We are supporting the body by providing the symptomatic support, and prazosin is to support the body to tide over the crisis. But if you are not realistic in understanding that this can be a scorpion sting, and you start acting on all the symptoms without acting on the actual causative agent, symptoms which are affected because of the synaptic level, because of the level at which potassium channels are blocked, because prazosin works on them. So that is the reason the prazosin is the most important drug in managing. Usually, if I ask 68 attendees at the moment, how many of your ERs are equipped with prazosin, I'm sure 90% will not have a prazosin. So my suggestion will be, in your emergencies, always keep charcoal, always keep prazosin, and I'll share one very good infographic and a small word document after this for everyone. Some 7 8 antidotes which should be part of every small hospital, every big hospital's emergency department, so that if toxin comes in your ER at any point of time, at least searching antidote and getting the dosage of antidote should not be a challenge. Uh, so, question is, do we directly push IV through central or peripheral? So, always remember, 20 years back, it was told that adrenaline, noradrenaline should only be given through IV route, through central lines. Now, even that we are giving through IV line, because the risk versus benefit of not starting inotropy versus starting inotropy, stabilizing in, and then going to PICU and putting a central line or an external. In these circumstances, I categorically mentioned that we kept a EJV, because when I was in a smaller setup where I have seen such cases, central line availability and affordability were challenging. So that didn't stop us from managing and getting a bigger central line. It is not pure central line, but it's a bigger vein, accessible and relatively very useful. So EJV also is a very important take home from here. Sir is showing, I managed a 4-year-old with cobra bite, presented with respiratory arrest, ventilated, given 12 vials ASV, recovered, didn't use atropine, neostigmine. Is it necessary to use atropine in neostigmine? Absolutely not, sir. If your child has shown improvement in cobra and you know it is a neurotoxic, then it is recommended. Like in your clinical experience, you were not able to give atropine and neostigmine, and you have to ventilate for 12 hours, and you have to ventilate for respiratory arrest for a longer duration. In our case, child self-extubated after 6 hours. So how I look at guidelines available to us is that every guideline comes with a asterisk mark which says that clinician discretion in every situation should be considered most importantly. So as a clinician, if you feel you don't need it and you want to manage only respiratory arrest, then you manage only respiratory arrest. You have given ASV and wait and give time. If you ask me, guidelines are curated after lot of deliberation, and there is always need of further observation while you are giving medications. So ensure that you keep on observing, maintain the utmost important monitoring in first 6 hours when you start treating such critical cases, because if you act fast and act right, child will come out and will self extubate. So that was the magic, and fortunately people recognized for this. My team was invited by district magistrate to a child who was being sent to a hospital as declared dead. Entire chaos of tribe has come to the nearby administration, and after 18 hours child walked into the home. So remember that magic happens only and only if we are doing it right. I'll go to previous questions also. Ventilator settings for snake bite management and how to win is, as you manage any respiratory arrest, you give support for ventilation. As the recovery starts getting better, the peak pressures, sensorium, secretions, agitation, everything you will be able to see on ventilator. And I don't think this is the right class to discuss on ventilator settings. So we will take this in ventilator settings. But in a nutshell, like you manage a respiratory arrest, you manage a respiratory arrest in snake, and respiratory muscle weakness in GBA, in Guillain-Barré syndrome. Similarly, you have to manage this case also. The pathophysiology is weak muscles, muscle paralysis, GBA, Guillain-Barré syndrome, snake bite, or central nervous system causing uncontrolled breathing difficulty. All these are muscle paralysis. You manage like you manage any other muscle paralysis. It takes a lot of time, but like Sir Nemo sir has told us in the end that he managed with ASV only. We manage with ASV, neostigmine, and atropine as well. Anti-snake venom, anti-scorpion venom is not available in India. I think I clarified in my talk itself. So with this, we have taken all the questions. If at all there are any other questions, I will be more than happy to take.
Sir, what are your experience with neostigmine in a crate versus cobra? Because I've seen crate doesn't respond to
It
neostigmine that much.
doesn't.
Yeah, because
No.
of presynaptic
Yeah.
venom.
Yes. It
Yeah,
doesn't respond.
it doesn't respond much. So it's just chronically ventilated patients.
Yes.
Sometimes it'll be about 2 weeks, 3 weeks ventilated, go for tracheostomy. So that's how crate has been so very notorious to
In
cause.
fact,
Uh,
12 days back in India, a new species of crate has also been identified. So we still don't know many things, and nature will unveil itself. We are talking about scorpion sting. We are talking about snake bite. There are certain lizards which are also poisonous. We don't talk about them because we
so
don't know about them.
yeah.
So, sir, now we have automatic BP cuff attached to monitor. Is it possible to still inflate the BP cuff? So, these are tips and tricks to make your ER more resilient. Having a manual BP cuff for a pediatric setup is mandatory. Why? Because sometime the cuff which is available and is attached to the system, um, if you have a doubt, you have a provision to take a manual BP also. And every hospital has a manual BP. There is no hospital or clinic which does not have a manual BP. And if you do not have, then it is better to have one. It is not harmful, it is useful. Till when to keep giving atropine and neostigmine? Technically, 6 to 8 hours. If you are dealing with neurological symptoms of snake bite, they start recovering in this phase. Scorpion sting and insulin, please explain, sir. So insulin activity decreases as a effect on the potassium channels, and intracellular blockade of potassium lead to in poor insulin availability by the cells. So that is the reason the ketone bodies increases, the fatty and the fat metabolism increases, and fat metabolism increment leads to deterioration, and gluconeogenesis start acting on the body. So insulin per se will become less active, and associated complications will be seen. If you are not identifying it well, this insulin related problem will also be seen by you. Your urine test will show more ketone bodies. There will be cells such as RBCs which will be using the cerebral for perfusion, and cerebral metabolism will be affected. Glucose, which is utilized at various level, will not be available easily, and for ultimately metabolic challenges will be seen more. Is there any news on a bedside test for confirmation of snake bite? I'm sorry, I'm not aware of this, sir. I'll read about it and let you know.
So you have almost answered all the questions regarding the management of snake bite. So thank you, sir, for enlightening us. So I hope there is no further questions, and we'll wrap up our sessions for today.
Thank you, everyone.
Yeah,
Thank you, Dr. Sundar, for
thank you.
thank
Yeah,
you,
sure.
IAP Delhi, to invite me, and thank you, everyone, for joining. It was a
Sure.
pleasure.
Thank you, everyone. Yeah, thank you, everyone. Thank you, sir.
Take care. Bye bye.
Yeah, bye bye.